For those of you, well, Brandon's kind of becoming like adjunct faculty to us now. He gave us a talk earlier in the year about robotics. Didn't you do that earlier in the year?
I think it's coming up.
Or it's coming up. All right. Well, cool. Well, we'll get to hear from you again here soon. But one of his passions is this concept of metabolic bone disease, and it's a great talk. Every year he gives it, keeps getting better. So, Brandon, thanks for being here. He's at KU. His mentor is like a great friend of mine, Doug Burton. And anyways, he has a tremendous history of spine surgery at KU with Mark Asher, who is like a really good colleague and friend of Dr. Akbarnia's. So it's kind of fun to see these parallel pathways in our lives. But without further ado, thanks for being here, and I'll let you get after it. Thanks, Brandon.
Yep, sounds good. Thank you, Greg. Greg and Bob and Dr. A are always so kind to invite me, and just being a part of this program and the fellowship out there, I think is just super fun. We don't have a fellowship in Kansas City, so maybe this gets allow me to touch sort of more clinicians that are going into spine or other clinicians that tune into the San Diego Spine Foundation. I think you guys do a phenomenal job. So I've added a few slides this year, so I'm going to try to go quickly. And if there's something that comes up that someone has a question, or if you want to save questions to the end, that's fine. I do have disclosures, none are relevant to this talk. So we all know that metabolic bone disease is a significant problem in our society and really worldwide. This is old data, but it's still the most commonly quoted statistic that over 200 million people worldwide have metabolic bone disease. You can see some of the data here from 2016 showing US census data that really 43 or 44% of people have some sort of condition that results in low bone mass. And really, I think it behooves me to be very clear, and I think it's interesting how clinicians, but also patients, really don't understand what is osteoporosis. And so this is the definition. It's a disease of living bone tissue that results in skeletal maturity or generalized skeletal fragility, in which both bone density and the quality are sufficiently weak that fractures occur with minimal trauma. And that's the key. The diagnosis evaluates the risk for a fracture. And so if we dig into a little bit more recent data, or statistics. This is from the Census for Health Statistics. They put out reports every few years when they get good census data. And you can see here, 43%, again, low bone mass. That's the U.S. population. And that's 2017-18 numbers. As you can see, clearly it's highest in women. That would make sense with the disease process. And really, it's kind of interesting, 12% of osteoporosis. That's a big number. That's a lot of people. And once again, it's the highest in women, 27%. We start to trickle down to a little bit more selective literature that's in the spine world. You can see this paper was in 2016 as well. And it illustrates 49% of all patients over 50 years had an abnormal bone mineral density. And then this is a paper I did when I was a fellow. And once again, shows 67% of people over 50 that came in having elective spine operations had abnormal bone mineral density. So that's a lot. I mean, 2/3 of the patients that walk in the door are going to have abnormal bone density. It's really a significant problem that we should be aware of. So what do we really need to know? I guess based on that background, you got to be really suspicious that everybody sitting in front of you today, tomorrow, next week is going to have some sort of abnormal bone mineral density. But why they have it is something that you sort of need to be at least familiar with investigating, and then determine whether it's something you want to treat or you can send to an endocrine specialist or a primary care. You also need to sort of evaluate, well, what does this patient need? Is this like a decompression only deformity or decompression only surgery, or is this like a big deformity operation? Is it cervical? Is it lumbar? How urgent is the case? And what are my options for trying to treat these people? So for a couple clarifying definitions, bone density. Bone density is the amount of mineral content in a bone for a given volume. And we call it BMD or bone mineral density, and some people call it bone mass. Those are analogous terms. Density is what we use for diagnosis. We can measure density. Bone quality is more about the composition and the structure. It contributes to how strong the bone will be, and it's completely independent of density. It's largely affected by bone turnover, microarchitecture, how the mineralization is laid down, and then micro damage. We have limited methods for understanding or measuring bone quality, and we don't currently use it for diagnosis. So how do we objectively evaluate bones? We've got a couple different things here: DEXA, CT, Hounsfield units, quantitative CT, and MRI. And so we'll go into these a little bit, and many of us have already heard of these. We're familiar with them. We use them daily. So I'll try to be pithy in my description. So DEXA, dual energy X-ray absorptiometry, was first uh, talked about or introduced in the 60s. It's now considered the gold standard for osteoporosis screening. We're familiar with how it works. They can do it in a lot of different zones. It's a two-dimensional picture, and then they have a zone of interest, as you can see here, this square, and the machine will quantify the volume of bone density in that picture. Advantages are low radiation, it's easy to repeat and trend, but it is less specific. And we all know that it doesn't work very well in the spine. In fact, it's not very highly recommended in the spine anymore, especially when people get degenerative conditions. They get significant sclerotic bone, and that will overestimate the density in that region. CT-based Hounsfield units, commonly used now. It's opportunistic. Many people get CT scans preoperatively, and so we use it and we say, all right, well, I'm going to do my construct in these levels. Let's go ahead and measure this density, but it's really just the attenuation. So it's really looking at, well, how dense was the bone on the picture? You put a little region of interest. Most PACS users or PACS systems now have an ability to do an ROI like this. It's very simple. It gives you a number. We use that number to sort of semi-objectively evaluate, is the bone density in this region sufficient to go through a surgery. The problem is, if you don't get a CT, usually then you're going to use a CT like this to get high radiation. It's not technically bone mineral density. You're just measuring the attenuation on a picture. And there's a lot of conflicting thresholds, and I'll show you those here in a minute. And there's a lot of confusion, even in the spine surgery world, between Hounsfield units, or HU, and QCT. So what's QCT? It's actually a software algorithm that converts the Hounsfield units based on standardized phantom data that is performed as quality check information on every CAT scanner all the time. And they use that through a software algorithm to convert it to actual bone density. So what I mean by that is they check your CT scanner in your health system regularly. It's part of compliance. And they use a phantom. And the phantom will then tell you, based on this dosing and this density of the phantom, what's my measurement? And it's just for standard quality check. Well, there's a company out there that uses this as a software, through a software algorithm. Use your QC data. They convert the Hounsfield unit that you measured through this software. As you can see here, it's in the axial and in the coronal plane, and they'll give you a number. And then the American College of Radiology actually accepts these numbers as diagnostic for different conditions, normal osteopenia, osteoporosis, and you see these numbers here. It is specific to cortical or trabecular bone, and so you can see how people put the ROI right on the zone of interest, and it'll be much more accurate in the spine for volumetric measurements, and it is technically bone mineral density and not just an attenuation reading. The downside, obviously, is that it's not widely available. Many people on the call probably are like, I didn't even know this existed. And it's quoted in literature and it's quoted at conferences, and a lot of people don't have access to it. So that's somewhat of a problem from our standpoint. MRI is another method of emerging way to evaluate bone and bone density and bone architecture. And really that's where it's headed, is the trabecular bone architecture is what a lot of people are really focused on. They're looking at fat infiltration of the bone, which is a surrogate for how much bone density and or the architecture. There's this ultra short echo time. It looks like a CT. There's actually a company out there now it's touting an MRI bone. Looks like a CT, and it's done through a special sequence. Advantages, obviously, no radiation. We get MRIs for a lot of things. You'd have to get the MRI at the hip to evaluate this, as you can see how this diagram looks. But the disadvantages is going to have you got to have a special scanner. It requires some post processing to estimate these mechanical properties. And we don't even have this at where I am. I know about it because I read about it, but I don't even know how I would order it. I'd have to talk to my radiology department and see if this is even possible, and it requires special software. So probably something that's coming in our world, and much better option than the radiation that we get with these other techniques, but not quite widely available. So who do we screen? I started to dig into this for a different talk that I gave at ISASS last year, and it's kind of interesting. You can find a lot of different literature options to tell you about screening for osteoporosis. So this is one I found. Nobody wants to read this. It's almost 500 pages. It has 13 different published recommended screening protocols across this 8-year span, and they're recommended in different countries, and they're all different varieties. And I'm like, geez, there's 13. Like, how do we settle on 13 different reasons, like 13 different ways to screen people? And then you go to more of a selected U.S. Preventive Task Services task force, and they have, some pretty broad, like almost too broad, in my opinion, criteria for screening women over 65 and postmenopausal women younger than 65. And then you've got this kind of indeterminate rating for screening men. So really, who should we screen? The WHO came out, and they're the World Health Organization. They came out with these criteria several years ago: females over 65, men over 70. But then also they kind of throw in there, which is fun, that anybody with risk factors, right? Medication, smoking, alcoholism, any history of a fragility fracture. And then what we kind of look at as spine surgeons, and sort of the relevance of this talk, is anybody planning for an elective spine operation, we now commonly screen. It's becoming a much bigger trend. So there was a paper, a very nicely paper done by Zishan up at Columbia. Big multi-center group here did this paper. I think this is definitely worth downloading and reading. It has a nice set of tables here. And you can see here, they really went into a lot more criteria, right? Like vitamin D deficiency, limited mobility or wheelchair bound, like great criteria. These are all great guidelines, things you can look at least put them in your media library in your head to understand, oh my gosh, this patient's here today, and yeah, they told me they drink a lot. Well, even though they're in their 50s, you might want to check their bone health. They do talk about a lot about DEXA and the CT measured Hounsfield unit as being opportunistic, but they don't have a consensus on the threshold, and that part's coming up here too. And then they do some evaluation and discussion about what kind of treatments. And this paper was done in 2021, and at that point, anabolic agents were the first line treatment. So we'll get into that here in a minute too. So what do we do? DEXA scan, easily ordered. It's a basic scan. It's a two-dimensional picture. It's pretty simple to obtain. It's low cost relatively, and with the right criteria, you can get it paid for by insurance. It's widely available, and through that data, you can put it into this FRAX score. The FRAX score is a standardized online decision tool that was developed for looking at people's risk for fracture. Interestingly, you should understand they do select the you see all these different options for their bone mineral density, and they all say femoral neck bone mineral density. I think that's a key point. You're going to look at their wrist or their spine, and oh, the bone density looks pretty good. And again, sometimes those are overestimating. The gold standard and what is widely accepted and used in the FRAX score is the femoral neck T score. So you should focus on that as your first decision and looking at it. Well, what about these other methods? We just talked about quantitative CT. Again, you can measure at L1 and L2 is the standard measurement. You use ACR criteria that I showed previously. And again, it's a volumetric measurement of the actual vertebral bone mineral density, and you can use that in the FRAX as well. CT Hounsfield units, again, very useful information. Many times it's opportunistic, not technically density, and there's a lot of controversy over the thresholds. And so this is kind of my little table that I built several years ago for this talk. And again, goes into the sort of the criteria you see. Left side here, the DEXA, we know the T-scores are, they're taught in first year medical school and beyond. We're all very, very familiar with those. The quantitative CT, again, ACR criteria listed here. And then these Hounsfield units, the no consensus one, but we oftentimes use because it's readily available and we're spine surgeons and we're, very busy. And if the test is in front of me, I'm going to use it, right? So the problem I have here, or the thing that I identified a few years ago, was, these are pretty dang close. Like, and I think this 110 number comes from a good paper out of Chicago. And that's what a lot of people focus on. They say 110, some people say 130. Every meeting I go to, I hear a different number thrown around, less than 100, more than 100, things like that. There's some definite numbers, like, in the 70s is a problem. But, when you get up into these 130s, you're kind of like, well, which one do I use? But the problem I see here is these are too dang close. And so when people start quoting these, these are completely different numbers. This is actual bone density in milligrams per centimeter cubed of hydroxyapatite. but this is actually just an attenuation number. And they're many times thrown around at meetings. I think that's an important concept that, hopefully people can take home. If you're using the Hounsfield units, you should know what number you're talking about and what it actually means. And so again, this one is endorsed by the World Health Organization. The QCT numbers are endorsed by or published by the ACR, but these are all mostly anecdotal, not anecdotal, they're published thresholds based on a lot of different criteria with no real standardization and no real consensus. So we just remember, again, all are very, very useful tools. You should know what each one represents and how you're going to incorporate that information into your decision tree. And then the DEXA is probably still the gold standard. It's probably the one that's most widely available for anybody and what you can track long-term as well. So what about this quality thing I talked about before? We just talked a lot about density. Well, quality is getting some attention, and it is difficult to measure, but there are some techniques using high resolution QCT, which is done at the wrist, and it can look at microarchitecture of the bone itself. And we know that the microarchitecture changes quickly. It's but as discussed before, the bone turnover will modify microarchitecture pretty quickly, and so this might actually be more important than the density that we commonly measure, but we're not really at the point where this is going to be incorporated into our daily evaluation or even our monitoring of response to treatment, things like that. There are other ways, as previously kind of touched on, the MRI-based bone quality is also getting attention. These are relatively recent publications in the 2020 era. It's going to be an emerging field. I know that in the next probably 2 to 5 years, it's going to really get dialed in probably for clinical use. Waiting for someone to commercialize some sort of software package that, gets bundled into all of our scanners. And then all of a sudden you can just click an option to get the bone quality measurement through the MRI, or they can do a single slice through the femoral neck or something like that. But it's definitely an area of interest. There's also this CT with finite element analysis. And this is another way people are looking at bone quality, really trying to understand, the forces that are happening through the different zones of the vertebral body and what that does for the density. We all know that the bones have different density in different regions, and you can do this at the hip or the spine, but it's not currently standardized for clinical use. And again, this is mostly research-based at this point, but maybe in our future, we're going to start seeing this hopefully be incorporated. Maybe it's a part of the CT scan that we can ask for an extra element of analysis, and then all of a sudden we see that, oh geez, the remodeling of this vertebral body at the UIV is much different than the floor below it, and it might change our decision making for surgeries. What about labs? So screening is largely image based for us, but I think that you'd be doing a disservice to your patient to not also obtain baseline labs for evaluation. These are the ones that are listed here. I added 24-hour urine collection. My endocrine team has really harped on me about this now. They think that that's a critical, it's a critical lab for them to decide about actual calcium levels in the blood. I don't know that I need to say or endorse on this, this conference that you need to order these on every single patient. I think that my go-tos are the vitamin D, basic, a CMP, which would give me the calcium and phos, a PTH, and maybe thyroid studies if they have a history of thyroid disease. If I identify some sort of abnormality and I'm referring them on, then I think some of these other ones, this 24-hour urine collection in particular, becomes the priority of the clinician that's going to go look into why do they have metabolic bone disease. But some of these top ones can really help you identify quickly, like low vitamin D, high PTH, high vitamin D. Like these scenarios are quickly identified. You're going to identify some people that'll have parathyroid disease unknown for years. And, I send those people over to my ENT service and they take the parathyroids out and their bone metabolism normalizes. So easy labs to interpret, not too difficult, not too much extra to ask. I think if you're ordering the DEXA, you could throw these in. I get them the same day that they see me in clinic, and then they get their DEXA a week or two later. So very important step, though, in getting the whole picture. So what about treating them? First off, I think, as evidenced by the literature that's out there, but also just sort of understanding, like this is becoming more and more prevalent of a problem, metabolic bone disease in particular, across the world. This is walking in your clinics. It's seeing you if you're not seeing it. And I think you need to really dig into why, Why do they have metabolic bone disease? Should I treat this patient right away, or should we delay things and get their bone health corrected? Again, really depends largely on what they need. I think that there's some people will make the comment, well, if they only need a 1 level, I can probably get away with it. I hate using the term get away with anything in spine surgery, but that's a decision you might need to make. And if their DEXA is only very mildly osteopenic, but they have really, really bad radiculopathy that's impairing their life, sure. But if it's a big deformity and you have time, I think that every one of us now focuses on getting this corrected so that we can make sure we minimize complications. And so lots of papers have been put out about this in spine literature. I think that the really take home for me, especially in multiple talks that I've given now, is there's some surgical things you can do, and I'll touch on those briefly, and those could be an entire talk on their own. But really the mainstay is pre-treatment. If you identify this, especially in deformity patients or even multi-level lumbar patients, you got to pre-treat them. Like, the medicines do the job. And if you get them pre-treated, you've really decreased your risk for complications. And so how do we do this? There's a lot of things in medications, I think, are the mainstay, and probably what I'll focus on the most here. You can see there's supplements. Obviously, those are simple. There's anti-resorptive agents that are listed here. And then there's anabolic agents, and there's really 3 out that we can utilize. In the supplement world, these are the standard recommendations. You're looking at 1,000 to 1,200 milligram a day of calcium. In the vitamin D segment, most recommendations are the 400 to 800 IU, but they're really getting up to a safe upper limit of 4,000 IU a day. If you see a patient who's really got like a crazy high vitamin D, that can be unsafe, but that's really difficult to get to that level with these types of dosings. Bisphosphonates, there's been published literature on this and in spine. I think these are getting to be older, a little bit more antiquated, given the anabolic agents. You can see these papers are all 2011 through 14. And yeah, they help, but really, I don't think these are the medicines that we all focus on and say, all right, I'm about to do a T10 to pelvis on somebody, let's put them on a bisphosphonate. That's certainly not what we're all saying. That's not how the message is being conveyed across multiple societies and spine literature, as well as conferences. You can see here, this is a table that was preclinical data on anabolic agents, or the PTH analogs. And there's really 2, Forteo and Tymlos, so the trade names, and it's the teriparatide and abaloparatide. As you might imagine, these increase the metabolic bone process. I kind of tell patients, I'm a common sense guy, like this turns on your bone machine. Like, we got to get your bone machine working. And by doing that, your bone density and your quality can both go up. And by doing that, we're going to decrease the risk for problems during surgery. And as you might imagine with these data, this increased fusion potential. So it makes a lot of sense. You turn the machine on, you put in all the right bone products during the operation, and the fusion will go up. Here's some additional ones on clinical studies. This was 2012, 13, and 14. Once again, all show positive results. Fusion goes up, screw loosening goes down, insertional torque goes up. Good things to happen in spine operations. So as we all know, and we're probably very familiar with, and I'm sure the fellows have seen, many of these anabolic agents are widely used during surgery, especially during deformity surgery. And there's good data that's supporting this tactic. Now, this is a new medicine, and this is the one that I think has the least amount of current data. And I'm sure we're going to see stuff start to show up as more time goes on. Romosozumab, or also known as Evenity, is an injection that's subcutaneous every 28 days. It's a monoclonal antibody, has a very, very low risk profile of complications. There is sort of a strange warning with cardiac patients, but it's not a consensus. I've still been able to have it be used in some patients with cardiac disease. It targets a molecule called sclerostin, and it definitely increases bone mineral density and decreases resorption at the same time. I think in patients that can't tolerate the other agents, or they get a side effect like hypercalcemia, this becomes the mainstay. Interestingly, this one's paid for by Medicare pretty readily, and its indications are pretty well spelled out. So if you have any of those indications, like high risk for fracture, postmenopausal, had a fracture while on another agent, then this can be easily obtained. I found that it's very, very effective. There's good literature behind it. The QCT analysis that was done in this study showed that the increased bone volume, bone content, and bone strength, all with Evenity. And just anecdotally, when I've used it in patients, I feel like the insertional torque that I haven't been able to currently measure, but by my own hands, is much, much better with this than even when I see 3 or 4 or 5 months of Tymlos or Forteo. Surgery techniques, as I sort of said earlier, you could dedicate an entire 30-minute talk to some of these techniques, but in my opinion, these are not ever going to be as superior to pretreatment. So I'm going to throw these in as sort of just the understanding that these are tools in your toolbox. These are things that you can consider, things you should consider in patients with metabolic bone disease. But pre-treatment is the gold standard mainstay. Like you absolutely need to identify patients, screen them, and then pre-treat them. These are other things you can consider, but they're never going to overcome bad bone health if you didn't pre-treat. Cement augmentation's been done. It increases screw pullout. We know it decreases screw loosening because of the same effect, but it may or may not impact the amount of risk for fracture, especially at a UIV of a long construct. We know that the cement actually load transfers, and so even though the bone that you augmented with cement might not break, the one above is now seeing a much higher load, and we've seen fractures above that. PJK prevention. I mean, Greg could probably talk for 2 hours on this, and we don't know. We're still trying to figure this one out, and we probably will for the remainder of the history of spine. I don't know, but alignment and correction goals are critical. Well, we have a lot of different methods for that, which we could go into, ad nauseum. Tethering, yes, minus, plus minus, you can do it. It does help in some literature, it doesn't in others. Is it going to overcome bad bone? No, probably not, because it might just rip the lamina off. UIV +1 vertebroplasty, again, load transferring, it just maybe propagates fractures higher. Cement augmentation, once again, was previously discussed, and PJK is going to always be a problem in long constructs, and bone health and pre-treatment, certainly is a component of that algorithm. BMP, off-label use in the posterior aspect of the spine. Again, for patients with metabolic bone disease, you need to get a fusion. The goals of some of these operations are fusion. And if you don't have some additional augmentation through maybe BMP off-label, you might not get your fusion, and then that's going to be a bigger problem down the line. We also know that surface technology is improving with our implants, and by doing that, we are also potentially increasing the ability of the body to recognize the implant and grow into it. And so again, in combination with the pre-treatment of some of these patients with an agent that turns their bone growing machine on, I think that can be a area of interest as well, or we already know it is. And seeing more and more data come out about that and surface technology and implants, I think will also be a key component for patients with metabolic bone disease. Cade subsidence. Again, this talk is not dedicated to surgical technique and or implant selection. There's a lot to be said about carpentry, and I think respecting your end plates as you're just doing your disc prep, no matter how you're getting there. If it's a posterior approach, a lateral approach, an anterior approach, it doesn't matter. If you violate an end plate, you're really increasing the risk for cade subsidence. Larger footprint implants, I think, have an advantage, although I just showed Greg a case, where I used a really large footprint implant and actually probably propagated a fracture. Guarantee that just by using the largest implant, it's going to be, that you won't potentially have a fracture. What type of substance or whatever your cage is made out of, PEEK versus bone versus titanium, porous titanium, porous PEEK. A lot of interest in the modulus of elasticity of the implant and how it might affect subsidence rates and or failure rates and fusion. And I think another thing in kind of the same conversation of respecting the implants is don't overstuff. When we really put a ton of tension on, the soft tissues around those two vertebral bodies within inner body, then you're really going to start to transfer some of those loads to the cage itself, and overstuffing certainly does that. Hardware pullout and failure, again, this kind of goes back to, how we get our fixation in the spine. Maybe there's improvements with navigation, robotics, things like that, pre-plant screws. I've certainly seen that I can get larger screws in with robotics, just because of the single pass trajectory and perfect line up to the cortical fill, things like that. But the other thing to think about is some of these cases, even shorter constructs, maybe it's 3 to the pelvis or 4 to 2 to the pelvis. iliac fixation is going to be really, really critical to preventing sacral fractures, especially when people have metabolic bone disease. Again, similar DJK rates are higher in patients with metabolic bone disease. Cervical cases, you're going to probably want to extend down into the thoracic region, get adequate anchors to support that kind of a construct. Percutaneous fixation, although we believe it could have been, the holy grail, it doesn't. I mean, again, maybe with navigated screws and bigger screws, your pull-out rates will be okay, but really this still just largely depends on the cage support. Subsidence, with laterals and A-lifts is theoretically lower than maybe a T-lift or an MIS T-lift, but not always. And really, we think, and I'm a believer in, preservation of the posterior tension band can help, but boy, you'll be surprised. If the bone fails, the bone fails. And it doesn't matter what's in the back holding it. There's only theoretical improvements here. And maybe every little ounce helps, but I still think the pre-treatment is probably the most important step for almost all of these patients. So post-operative care, I'll just briefly touch on this. This is, I think, the last one. If you put them on an anabolic agent, you're managing that. You certainly need to continue it. There's no consensus on how long you should keep it going. The anabolic agents, the three that are listed or that were available, we certainly know that all of them, and there's literature in the osteoporosis, there's papers in the osteoporosis literature that show us that if you do those agents for, let's say, a year or maybe even 2 years on some of them, and then just stop it without something to chase it, whether it's a bisphosphonate to lock it in or denosumab or Prolia, you'll lose all of that density that you obtain. So it happens very quickly, actually, and it's kind of discouraging. So there's something intrinsic to the biology of the patient, and if you don't lock it in with something, and that's a critical step, you're going to be right back where you started. Rechecking DEXs annually. I usually ask the patients to engage their primary care for something like this. And really, even though I did an operation on them, maybe a 1-level degen spondy like I'm doing this morning, what matters probably a lot more is that these patients don't get a fragility fracture in their lifetime. And you might pick it up as an opportunistic screening and say, oh my gosh, you've got osteoporosis or osteopenia, and really emphasizing to the patient like that thing, getting a fracture later in life will change your morbidity and mortality. And so that's really key. And I think that's a key component where we can kind of bridge across to a field of medicine that we're not really the long-term management of, but you might identify for a patient. As you all know, my senior partner's battling brain cancer, and just keep him in your thoughts. I think last year I said this, all the positive things you can throw his way or positive thoughts to Doug Burton, the better. I believe in that kind of stuff. And here's Greg, had him over for dinner at his house, and this is Dr. A, obviously, and this is at our institution. We've gone out to dinner with him a couple of times, had his wife and him over. So again, keep him in thoughts. Always think good, positive things. He's fighting hard and he's doing great right now. Any questions?
Awesome, Brandon. Thank you. Hey, one thing that you may have run into is those on Prolia initially. There's one paper out there that looked at a sort of a contradictory effect of going from Prolia to one of the, I can't remember which one it was, but one of the PTH analogs. I don't think they did both of them. I think it was just one of them. So there's some reticence from endocrinology to put them on anabolic sometimes after they've been on Prolia. I'll push back a little bit and if they're female, try to get them on Evenity, but it's something that some of you guys may run into that they won't help you or facilitate that transition.
Is that insurance or is that
no, it's because they lean on that one paper that showed.
Got it. Okay.
So that deleterious effect of the bone density from going from Prolia to the PTH analog.
Interesting.
Versus the other way around.
Yeah. How much are you using Evenity now?
It's a little more default just because it's a little easier. I think there are less side effects, but it's only female allowed right now. So for the men, it's Timlos and sometimes Forteo.
Yeah.
But I do think there's probably a little better data, even though it's early for it, and I think it's better tolerated in general. It's once a month instead of daily, so
right.
A lot of upsides to it.
Yep. My mom fell skiing a year ago now, year and a couple months, got a T12 compression fracture. I put her on it right away, and then we got a follow-up DEXA, and her DEXA normalized. Like she had osteoporosis,
Oh, wow.
and now is normal.
Wow.
So I'm locking her in with Prolia now, and I talked to one of my colleagues who's our chief of staff. He's an endocrinologist, mentor of mine, and he's like, Avenity's awesome. He's like, we love it, we love it. Like he's basically like all Avenity, and it all goes in waves like that when a new medicine comes out. But I have seen it's pretty dang effective.
Right.
So I think they're working on a male indication.
I'm sure.
Yeah.
I'm sure. Yeah, that will come. It just, the pharmaceuticals have to deal with the regulatory pathway.
Yeah.
But the history of how they discovered it's really fascinating too. If you ever look into that.
I will. Yeah. I met the guy who's on one of the researchers, but I don't know the history you're talking about. So I'll have to look into that.
There's a population that is homozygote for sclerostin inhibition, and they have heterozygotes and homozygotes, but basically the homozygotes are so calcified that they die early. They have all these issues from having bone formation that's so too aggressive. But the heterozygotes never get osteoporosis. They have great bone, and so they identified that population and the sclerostin gene involved in that heterozygote to homozygote dilemma, and then manufactured the antibody based.
Interesting. Very interesting.
I think it's South African.
Very cool.
Hey, Brandon. So in the patient that has lumbar disease, has bilateral hip replacements, and a DEXA that has the wrist, and the wrist for me, like I'm skeptical about its utility in diagnosis. But I see it a lot now where like the wrist is bad. It's like whatever, maybe make it 2.6. But like a lot of these patients where we get wrist and hip, say, the hips are going to be like relatively normal, 1.8 or whatever, and then the wrist is like minus 2.6 or times 2.7.
Yep.
Do you treat them?
I do.
Yeah.
Yeah, I know. I mean, the bilateral total hip person is a dilemma. And what I'll do, I think in those patients, I try to go advocate above and beyond. If I've got something glaring in front of me like that wrist DEXA, then I'm going to say, gosh, that's just the biggest clue in my head right there. So then what I'll probably do is go to their CT, measure their HU, dictate the bottom of my note, all the justification and my logic, and then maybe that's the patient that gets onto a peer-to-peer. Like, well, why do you need this anabolic agent? Okay, I would probably go above and beyond with that patient in particular. We don't run into that a lot. But, when you get someone on the phone and you say, look, this is spine surgery, like this is high risk stuff and the fractures are catastrophic. And, then I try to go that route. I certainly don't go, I try not to go the other way where I'm like, well, it's just the wrist. It's probably going to be okay. Even if I got an HU that looked okay in their lumbar spine, because I think there's a lot to be said about this quality component that we can't really fully objectively talk about right now.
Yeah.
And you might say, oh, their DEXA was fine. And then they blast their screws through their end plate or something like that. So,
yeah. Well, we know. I mean, there's certain conditions that will give you a false sense of security. Diabetes, even early prednisone use, you'll get a false sense of security because you get an architectural disruption more than you get a density drop.
Okay. But anyway, what's
Brandon.
up?
Hey, how's it going, man? Hey, question for you. So what do you do when you get discordant findings with a DEXA versus Hounsfield units? What I run into is someone will have a DEXA, which is minus 1.5, but you measure their Hounsfield units and their the levels you're going to operate on at 70, right? And if you don't have QCT, if you don't have trabecular bone score, some of these other things that will actually allow you to formally diagnose osteoporosis, a insurance company really won't understand or recognize a Hounsfield unit alone as a marker for poor bone and for actually getting a medicine approved. So what do you do in those situations?
Same as what was just mentioned. I fight hard even with a peer-to-peer. And if they don't do it, I talk to the patient and say, look, you should advocate for yourself, call your own insurance company. Some people will. We have samples. We're lucky. We have an osteoporosis nurse practitioner rolled into our spine center, and we'll give them samples initially and then still try to fight the good fight. Even if I have to do 3 months of samples, and I think that that's better, and maybe we can't do the full 6 months to a year afterwards. You're right, Benu. I get scared. I see some of these CTs, and you're like, those are shells. Like they just look like, vacuum like hole, and you know something's going on there. You know something's going on there despite the DEXA. And then I think this is an area of continued knowledge gap. There's like you said, it's discordant data. We have this 2-dimensional picture in the hip, and we have this 3-dimensional and maybe if we had a QCT, you'd immediately get an osteoporosis diagnosis. I don't know, but I still try to get the medicine in some way, shape, or form. I talk for a long time with patients about the risks associated with that. If that Hounsfield unit looks that low, I'm like, gosh, these bones look, they look pretty, pretty capacious, like almost like there's nothing in there. And they're like, really? And you kind of show them a different zone of the CT, and you're like, yeah, see how dense this one is? This one doesn't have much density. So I don't know. You and I are both on the same task force. What do you do for those types of patients?
Yeah, I think I do the same thing as you, that I talk to the patients a lot about what their risks are, even if I can't give them a formal diagnosis. I will try to modify my surgical techniques. Unfortunately, I don't have access yet to a bunch of samples and things like that. And I do not, unfortunately, have an endocrinology department that views these problems in the same way as I think yours does. So I just try to be very mindful of my surgical techniques. If I can stop a fusion within, like actually, there's a lady that I was going to do an L2 to L5 fusion on, for kind of a very, very small focal scoliosis with lateral grafts and percutaneous screws. But her L5 vertebral body looks horrendous. It's like a Hounsfield unit of 60, but because of sclerosis, 2 to 4 are like 200, right? So, I talked to her and I said, hey, look, I think your radiculopathy is coming from these levels. Why don't we just limit the surgery, because I think there's going to be a risk of fracture. So trying to, do what I can to limit the risk despite them having potentially bad bone. But you're right. I mean, all these tests are pretty, none of them are perfect, right? Each of them kind of give us clues as to what's going on. And if we can't hang our hat on a diagnosis with one of them, that's kind of accepted. Then we just have to modify or do something to try to protect our patients. So
yeah, definitely.
Awesome. Hey, Brandon, it's Ruwan. Can you hear me?
Yes.
Hey, great talk, man. One question for you. Do you have a preferred length of treatment for pre-treatment? Does it depend on the surgery you're doing? Or do you just have like a standard, goal for these patients? And then I'm glad you brought up Avinity. I've actually gotten a couple patients on Avinity that I couldn't get an anabolic agent on. But I find a lot in my area, at least, that patients don't get approved for the anabolics, or their copay is just astronomical.
Yeah.
So do you have any other tips and tricks for that? Thank you.
To your first question, sorry, tell me again the first question.
Length of pre-treatment.
Yeah, pre-treatment.
Goal for that.
Yeah, so again, I wish there was a better guideline. Even the consensus paper by Zishan was, minimum 2 months. That's just based on the survey they put out to those surgeons. And I'd probably look at it as more like, well, how severe is their bone health, and how big is the surgery? So kind of like what Benu just talked about, smaller surgery with very mild osteopenia, maybe it's just 3 months. I don't think there's anybody I do less than 3 months. But let's say it's a T10 to pelvis and they have osteoporosis. Well, maybe I do 6 months or maybe even a year, and I look at their DEXA again and determine, do we make some groundwork here? Like, do we make some headway? Am I going to be, happy with the results of this? So I think that my personal treatment algorithm comes from a lot of factors, and probably the severity of their disease initially on DEXA is probably the first thing I would look at, and then it's the size of the operation. For the pre-certs and insurance, all these Advantage plans are not Advantages, I found. So the Medicare Advantages and all these
The
other
disadvantaged planes.
the Disadvantage plans, yeah, patients don't have any idea about that. They're the same ones that have incredibly high deductibles, and I've heard the same problem. It's interesting. I've found even just like a remote 2 year ago history of a wrist fracture with being on calcium and vitamin D. You put it in a note, you write it all out, and many times Evenity will get approved. If you have like our center, it has to be administered in an infusion center or in an office where they observe you afterwards. So we have an infusion center, and luckily they use their own pre-cert team. I'm just, again, telling you how our system is set up. So if I see any sort of component and I looked at if you look up the Evenity indications, they're pretty broad, and like one of them is at high risk for fracture. Well, I go above and beyond in my note then to say this patient's about to have, a large operation with a risk of fracture of X and, the blah, 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 like put it all in there. Because the person on the other end who's checking the box that looks at it, if they read that, then they start to lean your way. And so I think in the patients that have really had a hard time with the Forteo Tymlos, because those ones are a little more strict in some regards, and they don't always get approved by Medicare. Even these Medicare Advantage plans, if they read the right indication on the Evenity order, then you can sometimes get it, which is interesting. So I wish it was easier. I wish they were maybe more generic. Maybe one day, I don't know where we're at on that if they're ever going to go generic and become, cheaper options. But with how effective these medicines are, I feel like we got to get to a point where it's not $4,000 a month for some patients.
Amen.
One other thing on the length of pre-treatment, I would just add is that I think the different medications also require different lengths of pre-treatment. So there's some data coming out that Evenity actually works faster than Forteo or Tymlos. And so if I put someone on Evenity, I'm willing to operate on them after like 2 or 3 months, whereas with Forteo or Tymlos, I tend to go longer, like 6 months, in terms of pre-treatment. And remember that Evenity, you only have a year total duration of treatment, whereas Tymlos and Forteo is 2 years. So, I've kind of gone the 2 to 3 months pre surgery on Evenity, and then continue it for a year, or continue for, whatever, 9 to 10 months afterwards, whereas Forteo and Tymlos, you have 2 years.
Yep. Definitely agree. My endocrine buddy, he said there's already people at their meetings talking about off-label additional years of Evenity, or you use your use a year now, and then 2 years later you can do it again. And again, I'm not indicating or standing here saying I'm going to do that just yet, but it might be coming in our future where they're going to expand their FDA indication to allow for an additional year later, things like that. So Vanu makes a good point, though. You kind of want to preserve some of something. Some people that were on Forteo and Tymlos and max their 2 year, then they only can go to Evenity. So sometimes if you can just do a year of one of those anabolic agents, you have another year in your pocket if they ever need another operation. It's like, deformity surgeries never have another operation, right, Greg?
That's right.
Yeah.
You do it right.
Just do it once. So
Same 100 patients over and over.
That's
Yeah.
right. They say.
Dr. A, it's great seeing you. I do need to jump off because they're paging me down to the OR. I think my PA's
Yeah, we just want
he's
to
hit
thank
his limit.
great talk, and we'll be there in archives in June. So
Oh, great.
Be there, but looking forward to see Doug tomorrow.
Absolutely. Absolutely.
Good
Maybe
to
I'll
see
see
you,
some of
Brandon.
you. Maybe I'll see some of you guys this week at IMAST. I'll be out
Yeah.
there.
Right.
Oh
We'll be
yeah,
here.
yeah.
Safe travels getting out here.
There.
Thanks
You
again
guys.
for doing it.
All right.
Take care.
Thanks, guys.
Thanks again.
Good
Have a
luck
great
with the
day.
case.
Thanks.
Great talk, man.